Hello, my name is Dr. Paulo Federico, and I'm a professor here at the University of Calgary. I'm very pleased to speak today as part of the ENIGMA-U initiative on diagnostic approaches in epilepsy. So today's talk will be fairly basic and probably around 20 to 25 minutes. First, I'd like to show my disclosures, and I really don't have any relevant to today's presentation. I'll now start with the definition of epilepsy. The new definition of epilepsy is shown here. It is a disease of the brain defined by any of the three conditions listed below. Number one, at least two unprovoked or reflex seizures occurring 24 hours apart. So if someone has a seizure related to hypoglycemia or other metabolic derangements, that's not epilepsy. They have to be unprovoked and they have to occur more than 24 hours apart from one another. The second is a little bit more difficult definition, but I'll simplify it momentarily. But it reads, one unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk of at least 60% after two unprovoked seizures over the next 10 years. What this really means is a person can be diagnosed with epilepsy if they have one unprovoked seizure and a diagnostically abnormal test, such as an abnormal EEG, CT, or MRI, which suggests that they may have a tendency towards seizures that presented itself for the first time. Third is a diagnosis of an epilepsy syndrome based primarily on the clinical features and history of the patient. Now, when we try and diagnose epilepsy in our clinic, the patient comes to us with recurrent spells. And recurrent spells may or may not be epileptic seizures. So the first thing we as clinicians have to do in the examining room is take a careful history and determine whether the spells are seizure mimics, such as syncope, transient ischemic attacks, migraine, movement disorders, amongst other diagnoses, or is it really a seizure? And if it's a seizure, is it true epileptic seizures, that is an unprovoked seizure, or is it a seizure that's organic, that is of physiological nature, but related to metabolic derangements, such as hyponatremia, hypoglycemia, drugs, alcohol withdrawal, amongst other things. If you determine that the patient does have epileptic seizures, then on the basis of history and investigations, we need to try and determine whether they may have focal onset seizures, that is seizures originating from one area of the brain, or generalized seizures, seizures arising from widespread areas of the brain, or whether they're unclassifiable at the time. So when taking a history as the first part of the diagnosis of epilepsy, we need to take a very careful history from the patient and any witnesses. And sometimes the witness for these events is not present at the time of the visit. So that's why I have the phone here. It's important to call the witness even at the time of the examination or the assessment to get a detailed history of the events. And when getting a detailed history, you need to focus on what's called the semiology. That is, what happens during the seizure. The patient may have several types of seizures, so you need to go through them one by one. You need to get information about what's called the prodrome, any sort of premonitory symptoms, the aura, the ictal manifestations, and any post-ictal manifestations. And you need to look for any lateralizing features either during the seizure or after the seizure, such as weakness on one side, which could suggest seizures originating from the contralateral cerebral hemisphere. Information about the duration, onset, and frequency, as well as triggers, is important, but it doesn't help diagnose where the seizures are coming from in the brain. But that's where this detailed description of semiology is important. And getting information about episodes of status epilepticus is also relevant because it may give you clues about ongoing severe epilepsy that may result in structural changes in the brain. Now, after you take a careful history, you need to perform some basic investigations. The first and very important investigation that needs to be performed is an EEG. And this should always be performed after the first seizure, and in certainly someone who has epilepsy who hasn't had an EEG performed. This will help support the diagnosis of epilepsy as well as monitor treatment effect. An EEG is a diagnostic test that was first performed in humans by Hans Berger in 1924. It is a tracing of voltage versus time recorded from scalp electrodes typically. A routine EEG recording is usually 20 minutes long, and a sleep-deprived recording is a little bit longer, 60 minutes, to help the diagnostic yield of capturing abnormal intracranial discharges in between seizures. The chance of identifying a diagnostic abnormality on an EEG within 24 hours of having a seizure is 51%. And if you wait more than 24 hours to get an EEG after a seizure, the diagnostic yield goes down to 34%. So in some centers, such as ours, we do have access to after-hours EEG. So if a patient comes into the hospital with an acute onset of a single seizure or multiple seizures, we try and get an EEG within 24 hours to increase the diagnostic yield. Here's what an EEG looks like, and the EEG electrodes on scalp. So electrodes are placed on the scalp in a very systematic way called the 10-20 system. And electrodes are put in the frontal polar region here, left and right, frontal, left and right, temporal, central, temporal, parietal, and occipital. And the EEG recording itself is essentially a recording of the difference in electrical potential between one electrode and another one. So the difference between this, the voltage at this electrode and this one will give the top trace here. And then the difference between this electrode and that one will give the second trace here, these two here, and then this one and this one here. And this is called the left temporal chain on the AP bipolar montage, otherwise known as a double banana, because these electrodes look like they're set up as two opposing bananas. On this montage, then the right temporal electrodes will be placed here, displayed there, I should say, and then going from front to back along the parasagittal regions are the next four traces, and then front to back in the right parasagittal, the next four traces. So this is what a normal EEG would look like on an AP bipolar montage. And the goal of obtaining an EEG is to determine whether the patient has epilepsy by recording the presence of what are called interictal discharges, which are brief abnormal electrical discharges that can be seen on EEG in between seizures. If it arises in one area of the brain, such as here, this is a focal discharge, and this would be consistent with a focal epilepsy. And if you see more widespread discharges, such as here, this would be more supportive of a generalized epilepsy. Now, imaging is very, very important. I'm not going to talk about the approach to the first seizure, but imaging must always be done in someone who presents with a first seizure, at the very least a cranial CT, and if you have the resources, an MRI. If someone has epilepsy or recurrent seizures, then a proper structural MRI must be performed, as it is a key imaging investigation, and it should be ordered using a seizure-specific protocol. And the International League Against Epilepsy Neuroimaging Task Force published an article, and I'm part of this, that recommends using what's called the HARNESS protocol. And HARNESS stands for Harmonized Neuroimaging of Epilepsy Structural Sequences. There are three key sequences as part of the HARNESS protocol. The first is a 3D MR acquisition of T1 weighted images with voxel sizes of 1 by 1 by 1 millimeter isotropic to get images such as this, which could be used to identify subtle structural abnormalities such as malformations of cortical development. Similarly, a 3D FLAIR fluid attenuated inversion recovery sequence should be obtained using a 1 by 1 by 1 millimeter isometric voxel again to look for subtle abnormalities. And thirdly, a T2 MRI, a 2D MRI of T2 weighted images acquired with smaller voxels, 0.4 by 0.4 by 2 millimeter with no interstice gap that are acquired perpendicular to the long axis of the hippocampus. And this is useful for looking for subtle changes in the hippocampus, specifically hippocampal sclerosis. When ordering an MRI scan, it is very important to provide a detailed clinical information on the MRI requisition, view the images yourself and a neuroradiologist to ensure no lesions are missed, and you can obtain a second opinion from an outside center if necessary. Now, here's some common abnormalities that can be seen in focal epilepsy on MR imaging. Hippocampal sclerosis, malformations of cortical development, low-grade tumors, trauma, stroke, vascular malformations, and granulomatous diseases. And here's a coronal FLAIR image showing one of the most common things we can see in our epilepsy patients, hippocampal sclerosis. The arrow is pointing to the sclerotic left hippocampus, where there's a decrease in volume of the hippocampus here compared to the contralateral side, an increase in signal. If you look more carefully on a coronal T1 weighted imaging study, you can see the hippocampal atrophy a little bit better on the left side compared to the right. Here's a coronal T1 and coronal flare image showing an area of abnormal gray matter that is also bright on flare imaging, and this is a cortical dysplasia. And here's a series of images showing a long-term epilepsy-related tumor, category tumors, which we now call LEAT. And this specific one is a dysembryoplastic neuroepithelial tumor, which you can see on the axial T2 weighted imaging as a bubbly lesion in the mesial aspect of the left temporal lobe, which is apparent on a CAT scan here, as well as a T1 weighted image. And this is with gadolinium, and it doesn't show much enhancement. So why do we do MRI imaging? First, it can help diagnose epilepsy. And in fact, about 25% of all patients with newly diagnosed focal epilepsy have an MRI abnormality. But it's also useful for determining whether the patient is at risk of having recurrent seizures and whether medications will actually control their seizures. If you look at this old study from 2005, the relative risk of seizure recurrence in a group of patients is higher if the MRI scan shows a lesion than if it doesn't. The relative risk in this study was 1.9. So those are the real important investigations for diagnosing and managing patients with epilepsy. Now, if they have seizures that cannot be controlled by anti-seizure medications, then perhaps we need to consider epilepsy surgery. And surgical candidates for epilepsy surgery must have a focal epilepsy that is resistant to at least 2 trials of adequately dosed and prescribed medications. And this stemmed from this old study here, which shows that 47% of all patients become seizure-free with the first trial of anti-seizure medication. And if a second drug is tried, then an additional 14% become seizure-free. And if patients require a third drug trial, then one reaches the point of diminishing returns where there's only a 3% chance of seizure freedom. And therefore, these patients are rapidly entering into this group here, which is drug resistant. So they must have failed at least 2 adequately tried anti-seizure medications. The seizures must be focal in onset for a resective surgery. They must be disabling, and they must have a well-established pattern that it's been at least present for 1 or 2 years. And there's a few other criteria which I won't discuss. So what are the pre-surgical investigations we typically perform? The overall goal is to identify the seizure onset zone, that is the area in the brain where the seizures originate from. And hopefully, if that area is resected, then the patient is rendered free. And if the patient is rendered free, then one can say that we identified the epileptogenic zone, which is the area of the brain which, when removed, renders a patient seizure-free. But the epileptogenic zone can only be identified post-surgically. So pre-surgically, we were just trying to determine where the seizures begin. And key imaging investigations include an MRI scan, which most patients will have already had obtained. Then they'll also have to undergo scalp video EEG monitoring. And this is where patients come into the hospital and have EEG electrodes applied to their scalp. And they are monitored 24 hours a day, waiting for seizures to arise. And then the video and EEG recordings of the seizures are reviewed to determine whether that all of the seizures originate from a single area of the brain that is surgically accessible. In addition, we routinely perform neuropsychology and functional MRI testing to assess frontal and temporal lobe function for patients with frontal and temporal lobe epilepsy. We do also perform other tests on occasion, and this includes a SPECT, which stands for single photon emission computerized tomography, using either ECD or HMPIO, which are tracers that measure blood flow. And when we measure blood flow in patients with focal epilepsy, sometimes hypoperfusion can be seen at the seizure onset zone in between seizures, or if we obtain what's called an ictal SPECT, where we measure blood flow during a seizure, we can see hyperperfusion at the seizure onset zone, such as in this image here. This patient had left temporal lobe epilepsy with an ictal SPECT. We can also perform positron emission tomography using 18-fluorodeoxyglucose, which measures brain metabolism, and we can sometimes see hypometabolism, at the seizure onset zone. And in some patients, if the scalp EEG recordings of seizures do not prove to be informative, they can undergo intracranial video EEG monitoring, where we can get more precise recordings of the interictal and ictal activity, either using subdural strip or grid electrodes, but more commonly now most centers use depth electrodes. Oh, and here's an image of a PET scan showing hypometabolism in the left temporal lobe of a patient. And lastly, we sometimes have to perform psychology and psychiatric consultations in patients to ensure that they have adequate support, both family support and emotional stability to undergo epilepsy surgery. So here's a scalp EEG recording of a right temporal lobe seizure. I'm just showing you the right temporal chain here in time. And as you can see, as you go from left to right, there is the onset of rhythmic activity here that over time builds in amplitude, so the rhythmic oscillations become higher in amplitude and they slow in frequency. And this is a typical temporal lobe seizure that originated from the right temporal lobe. So here's the same cortical dysplasia case that I showed you earlier. This patient also had an ictal SPECT, and this is a good example where a number of investigations are performed that are all concordant and pointing to a single area of the brain. Again, the area of abnormal gray matter can be seen here in the right frontal lobe on the T1 weighted image. That is a T2 hyperintense, and the ictal SPECT showed hyperperfusion at the seizure onset zone. So now I'm just going to show you an example of an implantation that we perform routinely now in patients who undergo stereo EEG. Depth electrodes that are shown here can be implanted in different areas of the brain, such as in the insula, in the temporal lobe, amongst other areas. And we then record their interictal and ictal activity. And with this technology, we can get beautiful recordings of seizures. So here's an example of an interictal discharge that you can see with the stereo EEG recording. And the seizure itself begins right here with repetitive discharges, which is very easy to detect, a lot easier than the scalp EEG recording I showed you, for example. And over time, you can see that the seizure activity spreads across the entire brain. So, and then what we do after we obtain recordings of these seizures, we just use these diagrams or these maps and plot out where the seizures begin, such as in gold circles here, where areas of early spread are, early spread by the squares, and then later spread in the diamonds. So the seizure onset zone in this patient was localized to the left, or I should say the right hippocampus. So in summary, quite simply, obtaining a careful history from a witness is crucial when eliciting a seizure history. And sometimes I would like to reiterate, patients with known epilepsy can have normal MRI scans and normal repeated EEGs, either routine or sleep deprived. So all you have to go by is the history that you've obtained and perhaps the response to anti-seizure medications. And EEG is a very important investigation for all patients with epilepsy. The MRI scan is also very important, and it's critical to use a seizure-specific protocol. And the one seizure-specific protocol we would recommend is called the harness protocol. And I would urge you to read that manuscript that I cited in the talk earlier. And any patient who has failed 2 anti-seizure medications should be considered for epilepsy surgery. And pre-surgical investigations there begin with video EEG monitoring recordings of the seizures, as well as the cranial MRI and sometimes PET and SPECT. And some patients do require intracranial EEG monitoring. And with that, I thank you for your attention.